interest about today's agenda? Are there any to come? Okay, well, I'd like to pause for a minute then and say something which is more interesting than a declaration of interest, but rather sad. So this is Renette Lucraft's last board meeting. I note from the minutes last time that we did thank you last time round, Renette, but we just we didn't do enough of it. So we'd like to thank you a bit more this morning. So Renette, you joined NHS Direct somewhat after I did, and you've been in the vanguard of the transition that we've made as an organisation. I think in two particular directions. One is the multi-channel and the becoming a modern organisation that speaks to people in ways that they want to speak to us. And the second thing is in helping us become a more efficient organisation and using our resources in a more effective way. And both of those things you've made an enormous contribution to. And it's been a great pleasure and delight working with you. Anyone who's worked with Renette, which includes everybody around this table, will know that Renette brings a particular kind of light to the table. She says it how it is. One can never look at Renette and know and doubt what she's thinking. She's been a fantastic source of energy and purpose in our organisation. But I mean, the fact is that the time that she's been here, NHS Direct has changed a huge amount, and our environment's changed a huge amount. And we, I think, have played the role of a disruptive innovator. And being a disruptive innovator is not easy. Being a disruptive innovator is really hard work, particularly in a system where we are bedevilled by very strong vested interests and decision making which is driven by forces which aren't always the most obvious, logical, right way to go. And being a leader under those circumstances is exhausting, actually. It's very tiring to continue to try and lay a trail in those sorts of situations, and sometimes when even within our own organisation we've resisted change. So I think it seems to me to be perfectly understandable that sometimes you feel you've made your contribution, it's time to move on and hand on the baton and take a break, and that's what Renette has decided to do. So we thank her for everything she's done. We wish her well in the future. We absolutely insist that she keeps in touch with us. And I'd like to hand over to Nick, who also will have some things he'll want to say.
Absolutely. Well, I echo absolutely everything that you've said, Joanne. And just on a light-hearted note, I am now working on the best man's equivalent speech that dishes as much humorous dirt as we can muster, but not in public, obviously. But no, we'll always be. We'll always be grateful for what you've done, and are very, very sorry to see you go. But there it is. Things move on, and people move on, and we will have another chance, as I say, to get partially even before you leave.
You're very welcome to say something now.
I will save my comments for the rebuttal to the best man's speech, I think. But I would like to say publicly, though, how much I have enjoyed my almost 5 years at NHS Direct, 4.5 years at NHS Direct. It's been a very much a learning experience for me. I absolutely adore the people with whom I work, and I know that I've made very many friends here that I can't keep me away, really. But I also sincerely hope that the future of the organisation is as strong as its past has been, because I am a consumer of healthcare myself, and when I need urgent emergency care in the future, I hope it's a NHS Direct person that I'm speaking to in delivering that care.
Very good. We need to speak up.
Oh, do we? Okay.
Gosh.
Fantastic. Well, let's move on to the minutes of the meeting which was held on the 26th of September. Somewhat less interesting, really. But any matters of accuracy? Alan?
I think this is one in 15.2, the final bullet, around expedient advice to handle more than one web chat. I think we also said subject to technical governance sign-off and such.
Yeah, absolutely. And we also have a
typo,
which I think I introduced. I can put my hand up for that.
Subject
Okay.
to the half and the web chat.
And there are probably more, and they're probably all attributable to me. Okay, so subject to clinical governance, and we can sort those typos out for the record. Any other matters of accuracy on the minutes? Nope. Okay, thank you. Let's move straight on then to the action log. So,
So all of the items are closed off, and we've put in the audit trail now, so you can see the outcome. And the West Yorkshire Urgent Care Service Quality Review will come to November. I did actually pick up there were 3 actions within the minutes of the meeting that we could just quickly resolve. The tripartite agreement has been agreed, and I believe it is now on our website. Is that right, Helen? Okay, it will be on our website very shortly, but it has been agreed and formal signatures attached.
And that's in respect of the foundation trust process?
Yes. Yeah. So in relation to 9.5, the second one that I picked up was in relation to the Chelmsford, Norwich and Ipswich sites under 19.4, and that we will be bringing some proposals to the November board meeting. Okay. And the third, which was 20.2, is to report that we have not concluded terms with the East of England on the appointments line contract, but we are hopeful that we will do so very shortly for a short extension, pending a national decision on choose and book in later months.
So is that date in the there was a date, wasn't there? November 14. Right?
Yes. So
is that date still relevant or
the
not?
contract comes to an end on November the 14th or 15th. The current contract, and before then, we have agreed terms, but the ink is not on the piece of paper yet, for a contract extension for the appointments line that will take us to April 31st of March.
2012. So
2012.
Okay, fine.
With some more detailed but relevant contract terms, which I can talk to the board about if you want me to. But that's where we are. During that period of time, there will be a decision to extend or not the choose and book system nationally. Nothing to do with our element of it, but more globally. And
are they likely then to go to competitive procurement for the telephone line?
We believe not.
Okay, fine. Just picking up another little action with some 6.5. Did we get I'm afraid I can't remember. Did we get the briefing sheet and original consultation document, Roger?
Yeah.
Thank you. Brilliant. All right. Fine. Yeah.
So is the date now set in relation to the consultation seminar of the 11th of November?
Yeah.
Okay. I'm on leave that day, sadly, so
that's okay.
All right. So going back to the action plan, I think we slightly changed that action, didn't we, on the West Yorkshire Urgent Care Service Quality Review. So what we're now saying is that the action plan, we clarified it. The action plan will go to the committee, and then the committee will report back to it. But anybody who wants to see the full Monty can apply to the chair of the Clinical Governance Committee, presumably, or the clinical director. Very good. Okay, thank you. Should we go on then into the performance section of the board agenda today? So let's just do this in 2 sections. Trevor, will you introduce the operational performance score, or the overall performance scorecard? We'll have a chat about that, and then we'll talk money.
Okay. You missed out.
I'm sorry, I've mixed up. That was odd. Trevor, if you wouldn't mind just pausing for a moment, Nick would like to talk about his chief exec's report, which I obviously didn't think was important enough to mention, but he's insisting.
There's only one item on my chief exec's report, which is just to report back. I think the majority of board members were involved in one or other of the 35, I think it is, board consultation meetings that we've had with staff, where we arranged for each of the sites in turn to close down and take everybody offline, and many staff who were not on duty came in as well. So I think they were pretty well attended. I don't know if you've actually got the final figure.
715 people attended those
face-to-face meetings.
But we're also setting up some webinars over the next couple of weeks for those people who didn't attend.
Yeah. So I'm sure that those of us who were able to go to those meetings will have come away with an impression, and I'll just share my quick impressions, that staff are very engaged with the strategic picture, where we are as a trust, and what that means for them and the service that they provide. And I think that's been really helpful, that everybody in looking at how we take forward rotas has had the opportunity to see this in the context of the organisation as a whole. But secondly, when you get into the detail of the rotas, many people engaged in asking questions about why this is proposed, why that is proposed, and we've been clear, and Roger and Renette in taking it forward, clear that we're making fine judgments about the balance of how we take things forward, and that those will be presented to the board at the seminar and in our final consideration. So I just wanted to get across that we are actively listening in each of these meetings, and in taking it forward, the board will have, I think, quite fine judgments to make about how we implement this.
Yeah, no, I'm sure that's true. I'd like to go to Roger, then I'd like to ask Keith what his impression's been, having been out and about and managing many of the staff who are affected. Roger.
There were some very significant themes and very important themes and very common themes that were emerging from the road shows, and the modelling team at Wakefield is now using those themes to model, remodel, model again the rosters to see where there might be compromises made, and that work is going on at the moment. And there are clearly some very important and finely balanced decisions to be made about the proposal that comes to the seminar and thence to the November board. So, you know, we are taking this stuff very, very seriously indeed.
Yeah, okay. I mean, that's good to hear. It's encouraging to hear Nick's point that people really understand why it is we need to change. Of course, there's a great difference between understanding that at the sort of global level and then working out what the implication is for me as an individual with my personal commitments and so on.
Absolutely.
And that's where it gets very tough.
Very
And that's what you're talking about.
Yeah.
Keith, do you have anything you... I think a microphone is heading in your direction.
I would echo Nick and Roger's comments about the general feel of the staff, that they understand why we need to do this. Again, I would echo Roger's comments that there were a couple of specific areas that caused concern for frontline staff, understandably wanting to understand what it meant for them, and that was mainly around the minimum working, the minimum of 15 hours, the minimum of doing that across 3 days of 5 shifts, and why that couldn't be 2 days of 7.5. And as Roger said, the modelling team have taken that feedback and listened to that, and have done some extensive remodelling to try to accommodate that. And that work is ongoing and will be shared very shortly.
Great, thank you. So I guess the messages we're taking away are that we're listening very, very hard to what staff are saying, and we are looking for the best possible alternatives to match up the needs of the users of our service, and the needs of the service, and the needs of our individual staff. So thanks very much for that, and we look forward to the board seminar and then the formal proposal that will come to the board. Thanks very much. Nick, anything else on your report? Okay, well let's move on then, as I did prematurely, to the performance report.
Thank you, Chair. Brief headlines from the month. We had 353,000 users of our core service. We had 561,000 users of our online health and symptom checkers during the course of the month. In terms of our performance levels, they remain broadly consistent after the improvements that we'd seen in August. Our financial performance remains strong, with a year-to-date surplus of £1 million, a cash balance of £17 million, and we remain on forecast to deliver the planned level of surplus for the year. I would like to apologise to members that we have got an incorrect version of Appendix 1 included within the papers. We will be recirculating that and putting that onto the web. I would like to be reporting the forecast outturn of 4.8 million, but that is an error. It remains 266,000.
Okay.
Fair enough. Okay, does anybody have any questions for Trevor or anyone else about the performance package? Trevor?
2 points I'd like to pick up. The first is the expert call review target. It's currently at about 67%, and the target is 80% to be achieved by November. I was looking for reassurance that we will achieve that by the due date.
Chair, we have been working closely with the expert core review team, and one of the key areas which is taking the team's attention and feeding back to staff is with regards to documentation.
Could I just pause you there for a fraction? Because I would welcome clarification about, are we below target because we're not achieving the volumes of expert core reviews, or is it the scores? It's the scores.
Yeah.
Okay.
We're reaching the target, so every member of staff is having 1% or 3 of
Okay.
their calls.
So we are getting the
Yeah.
coverage that we need,
Yeah.
but we haven't quite got the proportion of good and very good that we're looking
That's
for.
right.
No. So going back to you.
Yeah, so the key trigger, which is having an impact on us reaching the 80%, is staff's recording of what they've actually said to a patient. So they are saying things to a patient which are not being recorded in the patient's notes, or the other way round.
Could I just pick up on that? Because I noticed, partly from my own experience in contact centres, and also it was an issue that was raised by the West Yorkshire Urgent Care Report, which is a question of the ability that our staff have with touch typing. And I've certainly seen members of staff who struggle to do anything more than one finger typing. And the West Yorkshire Urgent Care Review suggested that we should be offering touch typing training to our frontline staff. Do you think it's ability to type quickly that may impact that?
It's a combination of both. Within the patient record, there are tick boxes, so standard things
there's
that
not
you
much.
respond, you can tick box, and then sometimes they're ticking something to say they've said it and they've actually not given the
Okay,
patient
so that's
that
clearly not a
information.
typing issue.
It's a contribution. There is part of the patient record where you can add a verbatim summary of what's been said, and touch typing is something that can impede in the accuracy of what's being said in that part of the patient record. So it's a combination of both, but that's the key area which is causing staff to fail their core review process.
Okay. So it's documentation, it's not the quality of service
Absolutely.
per se, although clearly that is very, very important. And are we doing anything to upskill our frontline staff in relation to their typing ability?
Yes, when staff have identified that they have problems with typing, there is an e-learning package where you can use to help you with your touch typing skills.
And do we know how widely that's used?
I don't know. I can find out.
I don't think we need to have that as an action. We can maybe have a chat about it. Steve?
I've got two very quick questions. In terms of total core contract volumes being below plan levels, is that including what we had estimated for the 111 pilot? Because it does say. So is it still below, even though we've taken that into account?
Yes.
And is it compensated at all by an increase in interface with the website?
There has been increased usage both through the website and through mobile applications. So there has been a compensating increase on those.
Okay. Thank you. Trevor?
Yeah, my second point was, just looking at the raw statistics, I noticed that 80% of calls coming into the new 111 system are being referred to other parts of the NHS, compared to approximately half that for the traditional NHS direct service. I'm not expecting an answer to that now, but I would like a little bit of research to understand why there is such a variation. It could be argued that we're putting much more pressure on the rest of the NHS by referring calls on into the new 111 system. So it would be good to understand that, I think.
I'm sure that's something that's attracting a great deal of consideration. Nick?
It's highly relevant. One of the concerns when one is looking at the downside scenario for the introduction of 111 is that it increases demand in face-to-face NHS care. And clearly that would be an unwarranted and unhelpful addition to demand. So we are closely focusing on that issue in the pilots, and I'm sure that the Department of Health in their formal evaluation through Sheffield University will be addressing that self-same issue. But it may be that we can come to some more interim or preliminary reviews and feed those back to the board.
Tim?
Just to add to that, thank you, Joanne. I know I'm getting in the queue here, but the second to last bullet that we've got in the summary, where pilot areas have 17,000 calls in September, more than 10 times the declining number. So not only is the proportion closed out increasing, the number of calls is increasing as well. So there's almost a multiplier effect.
Yes.
Very
Yeah. Yes. Okay, I'm sure those are topics that will be that are already, as I say, being looked at very carefully, and which we will return to. Any other comments on the performance package or questions about it before we move on specifically to finance? No. Trevor, do you want to just... Tim?
Sorry, yes, I've just noted on, I think we'll note this section, on B2, which is page 2, then on page 3 of 12, we've been running for a year now with complaints below a level of 0.4. That, I think the team should be congratulated on that. And we normally look at these and worry about the numbers going the wrong way, but now we've got some numbers that are looking pretty good.
Thank you.
Great. Very good. Trevor, do you want to say a few words about money, or I mean, you captured it at a high level? And
I guess just to supplement what I've said already, our surplus for the year to date is broadly in line with plan and has remained so for the year to date. We have been proactive in trying to secure our position for the year through the locking in of quarter 1 underspends, through the identification and hard coding of additional CIPs, and a careful identification and management of financial risks across the service. And that remains the position, and we'll need to continue to do that. There are a number of risks because of the degree of change the organisation is going through and the uncertainty that we're subject to. So we will need to continue to carefully manage our position for the remainder of this year and beyond.
you always tell us that, Trevor, and you're always right. And we're always very pleased about the position that you're reporting to us. So thank you very much indeed for that. Are there any questions about the money? Peter?
I would like to also just say it's very pleasing still to have the continuing stability that's projected to the end of the year, particularly as I know from elsewhere in the health system there's a lot of volatility and difficulty that's emerging. So we must keep that up. I wanted to just say that the cost improvement program has been fully identified and said will be delivered. So I think that's again another positive.
Peter, can I ask you to speak
Oh, sorry,
up?
yes, I should know that. Sorry. I said again, and the 5.4 million cost improvement program has been fully identified and will be delivered. And I think that that's very, very good progress that has been delivered with a vary for a while. It still has to be delivered, but it said will be delivered. There are some, I just wanted to come to these cost pressures. So we've got 2.5 million cost pressures. My main concern is that they are relatively, I think, straightforward in the way that they've been described to be delivered. There were two bits to it. One is the contribution to the winter pressure funding, so that we've got to do. I mean, that's an imperative. So we just wanted to hear a bit of reassurance about that. And the fact that we've got to deliver our KPIs to ensure that we don't have more penalties. I see that as part of the process. So in fact we'll be on our mettle, as it were, quite continually. Other than that, I think it's a very satisfactory position, but I'd just be grateful for a couple of comments, if I could get them from either Ronette or Trevor, about the cover for the winter pressures.
Yeah, I'll be happy to certainly start that. We secured an agreement with the East of England, which, broadly speaking, brings £3 million into frontline service provision to secure service levels throughout the winter period. We're progressing with the schemes and recruitment of staff on that basis. Part of that arrangement did include an application of our contingencies and reserves on a non-recurrent basis. So we secured what we believe is a good deal for the service and for the users. Equally, we have seen improvements around performance levels, which we're looking to continue and sustain further throughout the remainder of the year.
Thank you. Anything else? No? Okay. Well then, we can talk about risks.
Just make a quick comment before I ask Helen to come in. that there was discussion of the risk register version that was being presented to the audit committee, and I felt uncomfortable, as I think a number of people did at that time, and as a result of that, we had a pretty thorough review at the exec team last week, and as a result of that, the risk register that you see before you has been pretty well scrutinised collectively by the exec team. So I just wanted to put that in before we get into the detail of discussing particular items.
Trevor.
I wonder if we could have a wee bit more detail on the only risk which has increased in the period, and that is the issue of industrial action. Just to get some detail on what the internal NHS directive might be.
Absolutely. This is something that Roger, Renette and Keith have all been working on, but essentially we do face the potential for industrial action on the 30th of November alongside other public services affected by a potential dispute over public sector pension changes. Clearly we're not in a position to be negotiating about any of that. Our job is to maintain services to patients, and that is our focus. So I don't know if, Roger, you've been in discussion with trade union colleagues and Keith and Renette looking at the operational aspects of it.
Yeah, I think on the position we have at the moment is that of our we've got a trade union recognition agreement with 4 trade unions, but there are 2 principal ones, that's Unison and the RCN. Unison are out to ballot at the moment on the day of action on the 30th of November, and the RCN have decided not to go out to ballot. So the principal union that may undertake industrial action will be Unison. Whilst the trade unions aren't in a position to talk about the 30th of November until the ballot is over, we have made it very clear to them that it's our role to ensure that patient safety is maintained on that day, and that is what we will do. And the response from our staff side colleagues at this stage has been that is our position as well, and so we will also ensure that patient safety is maintained. So that is the position we have at the moment. We are developing our own contingency plan, which will be very specific about what level of staffing we need to maintain our service so that it's safe to patients, and we will be very clear about that.
Thank you. That's very, very helpful. Did you want anyone else to comment on that? That seems to cover it, actually.
I think it covers it.
Okay. Anything else on the risk register? Which I think was admirably focused. That seemed to me to be a very positive way to present it. I mean, it was interesting. Yes. Well, we're very supportive of that, I think. But I'm very supportive of that. Excellent. Okay, so we're now into the next section of our agenda on governance and compliance. There, I think, we will find relatively little to discuss under the use of the trust seal. If anybody wants to, they're obviously very welcome. And then we have reports back from the audit committee, first of all. We've got the agenda for the 24th as a sort of aide-memoire, just so that we can see what was discussed. And we've got, yeah, that's right, isn't it? And we've got a sickness absence report, which we went to the committee on the 13th. Okay? Well, yes, if you'd like to, or people can question you.
A few comments. You just mentioned about, we did have a good look at the board assurance framework to tell the board that, and the corporate risk register just mentioned. The internal audit programme, we reviewed 8 reports.
8?
8. 8, yes. In some detail. 6 were substantially assured audit opinions, so that is highly commendable. 1 was adequate assurance. We unfortunately had some line problems in getting people to come into our meeting out from on the phone. So we were aiming to talk to the management of Wakefield that was part of the review, but we didn't manage that in the end. But we did have quite an attendance of the senior management or senior executives, so we dealt with it that way. And there was limited assurance opinion on sickness absence. So perhaps I could just say something about it.
Yes, please do. I mean, as you know, we're very interested in that.
Yeah.
As a very important.
And the audit committee spent some time on this with our internal audit colleague and our senior executive colleague around the table today. There is no doubt there were some weaknesses in the system, and that's been acknowledged. And having the internal audit review has helped to ensure that appropriate accuracy and system review does take place. We had some helpful discussions with the internal auditors. Obviously Roger and Nick and Annette wasn't there on this occasion, were you? But in terms of just a lot of detail, obviously that is something that the audit committee was quite good at. And I must say that in the end, I think we were reassured that the information that's coming to the board through the monitoring systems is adequately monitored and tracked, has appropriate senior management sign-off, and although there have been some inconsistencies, largely in long-term sickness, we were assured that the mechanisms produce accurate data to the board from the scorecard system. So I think that was something that was concerning us, but we did discuss that in some detail and found that we were reassured about that. I think the problem is there are three systems in place, and we did ask if the actual review could be brought forward to actually get the work done earlier so that we could have one system, and therefore people feel that that was going to reassure us again. But we are clear that that is not possible, but that in the meantime there is no inaccurate system in place, so the data is accurate. I'll say it again, the data is accurate.
Data is accurate, but the systems are slightly
We've got
suboptimal.
three systems, and therefore they need to be coordinated and pulled together, and that's the job that it takes on in making sure that happens. And also, of course, the executive general management and making sure the managers do the job they're meant to do in the first place, which is to fill in the stuff and send it on. Subsequently, I have had that assurance directly from the executive management team, and I can say that all the outstanding recommendations of the internal audit from 2010-11 have all been implemented, but the audit committee will review the second internal audit monitor in January, when there will be a second report, so we will have a look at it again there, and we'll report to the board. We know how much the board feels that this is a vulnerable area, and so we're keen that we keep a very close eye. So that's that. I don't know if anyone else wants to comment.
Sounds like one or two people might. Steve?
Well, it's really just a question of clarity. When I read this, I sort of got the feeling this was about process, about paperwork, reaching the right files, etc. Am I right in assuming that the on page 4, the obviously improving compliance is itself contributing to the increase in sickness reporting?
No,
it's not. That's fine.
Absolutely
Thank you.
That's a separate exercise.
Yeah, that's fine. Thank you.
Anything else on the sickness reporting? No. Okay, thank you, Peter. That's very clear.
Two more things. One is
Sure.
we had a very useful introductory meeting with the new external audit team, and we have had our first discussion about the year-end results and programme, and there are no significant new risks to report or at the moment. That it's all moving on nicely. And the only other thing I just wanted to mention, because I think we should mention it here, is under health and safety. We did have some concerns about completion of fire training. But I have been assured by the executive management board that all mandatory training needs will be completed appropriately. So had that assurance, and I thought we should appreciate that was an issue that we spent some time. Other than that, no further comments.
Thank you, Peter. Anyone else want to make a comment or ask a question in relation to the audit committee? No. Okay. So I've lost myself here. No, I haven't. Okay. Finance committee.
Yes, thank you, Joanne. We had a finance committee on the 13th of October. I think you've got the agenda. Just to very quickly run through a couple of things that we looked at. We looked at the procurement improvements, where there's good progress in reducing the number of suppliers, and I think the overall view was we encouraged the management team to do a bit more. And I can't remember the numbers, but we certainly had a substantial reduction. So there's a good plan there, which if we could accelerate, we would like to, but I guess it's a resource limiting issue. We also looked at the costs of the Our Future programme, and there are some minor changes and variants which I think the Finance Committee were understood and were happy with and noted, frankly, so that there was a bit in Phase 2 that's been brought into Phase 1, but nothing significant that we think the board should worry about. On financial performance, I had the sort of rather easy ball across the top of the net on capital, and we looked quite hard at the rate of spend of our capital programme. We don't want to get to a position at the year end where we're underspending, because these are all got good business cases and they're all improvements to the operation. So I think we encouraged the finance team to accelerate there, or actually just to hit the budget would be fine, on capital. And on business cases, we're beginning to see, and for the first time, I guess, the number of bids that we're going to have to deal with in 111, and Ruth circulated a good report to us, and we commended that the board needs to keep a view of that list of bids. Particularly some bids we're deciding not to bid, and we asked for some criteria, for some no bid criteria, which I'm sure we're going to talk about in the next couple of days, actually, Joanne. So
good.
We were very encouraged that we're beginning to see a clearer picture of when these bids are going to come out, and which of the local commissioning bodies are going to be at the forefront, which are a bit behind. So we noted that, and we encouraged Ruth, and we think the board will be interested in that. I think that's about it, unless my colleagues want to add.
Any questions to Tim on the Finance Committee? No? Okay. Thank you. Well, I think that completes the governance section of the agenda. We have a reduced stakeholder engagement section. We decided not to put in our usual CD of contacts with patients and the public, specifically because we wanted to create as much time as possible for our strategy day going forward. I think we will return to that because we want to continue to place a real emphasis at the board table on the service that we deliver to the public. But that's not what we're not going to look at that today, nor are we going to spend any particular time looking at internal meetings and engagement visits that we, the board, have been making to the outside, to other parts of the NHS Direct organisation. We covered that a little bit earlier on, and we're not going to spend any more time on it today. So, do we have any other business to report? Anything anyone wants to raise? No? Then I think we have come to the end of our board meeting today. The board will meet again on the 28th of November here at 10:30, and we can close. Thank you very much.